Mr. Chairman. So, we know, because it was published a long time ago, that after an acute myocardial infarction that was treated in the best way with primary angioplasty and with perfect opening of the vessel that is involved, in spite of that, significant left ventricle dilatation occurred. And this happened in 30% of our patients treated. And what is really interesting to know that when patient had angioplasty, never the cardiologist read in report the volume of the ventricle after the procedure. And this can be a very important thing. And there is a lot of discussion about restoration of the left ventricle, and I would like to bring two examples that are too extreme from the bell-shaped curves. One is a patient with relatively good ejection fraction that got acute myocardial infarction in 1981 and was in relatively good condition until February 2010, when was hospitalized for syncope without evidence of major arrhythmia, and the ejection fraction was 40%. This man, before this episode, was a runner in spite of his age, that he was 73, 74 years. So he got angiography that showed clinical stenosis on left anterior descending that was responsible for this old infarction and occlusion of marginal. Because he had a syncope, he received ICD. And this is typical treatment for this pathology, but after a month he had a new syncope with ICD shock and evidence of SVT, and he got again a PCA in marginal obtuse, but even there is no evidence of ischemic at stress test, and this also is typical in our historical period. From September 2010 to February, he had multiple episodes of sustained ventricular tachycardia interrupted by frequent appropriate ICD shock, and the quality of the life of this patient was really very, very poor, because of course he was feeling when the shock was arriving. It seems that this is not nice at all. So finally, the cardiologist decided to send the patient to the surgeon, and the surgeon performed SVR with a sized balloon 110, and the ventricle was correct with a Dacron patch, and a graft on the left anterior descending with the mammary was performed. And this is the patient before. And you can see that there is a good basal portion with a relatively small ventricle calcification. This is a classical person that can react beautifully to the intervention, but he had, as you can see, a ICD. And this is the patient after the procedure. You see that he has normal ventricle, good ejection fraction, and after 2 years from the procedure, the patient is doing well in class 1, no ICD shock, no arrhythmias at ICD interrogation, a restart to run. So if the good thing will be done immediately, our society will have saved the money of the ICD, and the patient will be in much, much better condition for a long time. This is the other extreme of the bell shape curves, a patient that had normal coronary arteries, but this is the patient that he got acute myocardial infarction. He had a successful, a great result of primary angioplasty. The problem is that in spite of that, his functional class was very poor. He was in class 4, and you see that he had a defibrillator and resynchronization therapy. Why? Because this is the ventricle, this is the patient. You see that there is important dilatation of the ventricle with very poor contraction in this anteroapical inferior zone, and you see where is the resynchronization catheter. It's very far. It's impossible to hope that this patient can improve his contractility with this. The patient was listed for heart transplant. The patient decided to refuse heart transplant, and it was operated with reconstruction of the left ventricle, and this is the final result. The improvement of ejection fraction, reduction of the volume, and the shape, it's acceptable one. The patient was a 67 years old man. He was a ski man. And 1 year later, he sent me this postcard from Cellaronda in the Dolomite. It's one of the most beautiful ski resorts in the world. And he did the Cellaronda. Probably there is some people that is skiing in knows Italy. Know this 45 path to downhill, and he was successful at the end, and he wrote a postcard. So from patient that was listed from the heart transplant, we arrived at ski man that he have a normal performance in this activity. The procedure is technically simple. When we have a patient, in this case, in this cartoon, that he have occlusion left anterior descending, the cavity is enlarged, as you can see here, and as you have seen in the previous presentation, the papillary muscle are displaced toward the lateral wall, and of course, the ejection fraction is reduced in a very important way. But of course, a portion of the ventricle is still working. So this is the MRI of this patient. You can see that there is a basal portion is working, but we have a huge dilatation. MRI, it's really very important to decide how is the remote zone, and all procedures is based on the quality of this zone. So we open the ventricle, and we define which is the line between the chronchorectal area and the scar tissue, and with a suture that is running in transitional zone, we delimitate the good tissue and the bad tissue. To be sure that we are not restrict the cavity and to preserve as much as possible the elliptical shape, we use a shaper inside, and after that the ventriculotomy is closed. In this particular case, is closed with a patch, but it can close when the anatomical situation is favorable. It can be closed directly with a direct suture. As you can see here, the patch is going very oblique toward the septum upper versus the aortic valve. Same thing, and it was the patient that I presented before. If the dilatation is in inferior wall, and this was the dilatation on the infralateral wall, and this is the same patients treated with exclusion of that. You see that the shape now is perfect, and the contractility is increased. Of course, the magnetic resonance is really very important, and this was I think that the answer that Ottavio Alfieri asking for. If I know that there is this long situation that it was completely scarred, I can exclude that from the cavity, and the papillary muscle are pushed together. And due to the fact that this diameter is not enlarged, but it's normal, the possibility that the mitral valve is fixed, only fixing the ventricle, is very, very high. And so the technique is very simple. We put together the point A and the point B that are the extreme, the scar. We put together, we reduce the diameter, and we replace very simply the papillary muscle in the right place. Which are the indications of SVR? The indication, of course, is a previous anterior or inferior lateral myocardial infarction that can be documented by echo, by cardiac MRI. Left ventricle dysfunction, a kinetic or dyskinetic with increased volume. That's important. This is a reduction surgery. The volume must be big. Big how much? More than 60, and we will see after why. When is it hypokinetic? That means that there is no transmural scar, so probably in this case only revascularization is enough. Heart failure symptoms and intractable ventricular arrhythmia are a good indication, and I think, and I can be wrong of course, but I think that patients with enlarged left ventricle with no symptom of heart failure but needing to be revascularized are patients that have to be treated, because we know that this situation is an evolving one. Which are the limits? Of course, when there is both ventricle, right and left, dysfunctioning, this can be absolute, but sometimes it's difficult to find a right ventricle dysfunctioning, so we have very carefully analyze the right ventricle, and that can be done with MRI, of course, and if there is doubt, with echodobutamine, just to see if there is some improvement of the right ventricle under the stress. When there is no dilatation, this is absolute contraindication. There are relative contraindications that are pulmonary hypertension and restricted diastolic pattern. This is relative because we know that in this case the mortality is relatively high, but very often these patients are old, they are in full treatment, there is no other option, no transplant, no VAD. So this is an ethical problem that must be discussed very deeply with the patient and with the attending physician. The MRI is really very important because it can give us, with one examination, the extension of the scar, the volume of the ventricle, and that is more and more important, the quality of remaining tissue, because the patient lives with this and for this tissue. This is the four-chamber view. You see that almost half of the cavity is involved in a scar in this particular patient. And with the new software, it's possible to know exactly which part of the ventricle is good one in terms of contractility, is normal, which part is transmural, the deep blue transmural scar, and which part of the ventricle can improve if we revascularize the patient. This is an example of huge transmural scar before and after the procedure. The ventricle, the volume is really smaller and the patient is improved. The BNP is reduced in a very important way. This is four-chamber view, same thing. Look at the relationship between the apex of the right ventricle before and after, demonstrate the reduction, the important reduction of the volume of this ventricle. With this scar that you can see, it's a very large one. Always with MRI, it's possible to see how is react the patient after. This is the bull eyes that show clearly that all this zone, the yellow one, is completely akinetic with this extension of the scar. After the procedure, there is no more akinetic, there is this hypokinetic, and the reduction of the scar is really evident. More interesting are the digital numbers. You see, this is one example of patient that you have an important reduction in volume, in systolic and diastolic, in improving ejection fraction. And if you see the extension of akinetic is reduced in an important way, the reduction of late enhancement gadolinium is reduced in an important way. One thing that must be taken account is the basal ejection fraction. So this is the portion of the ventricle that is not involved in direct surgical procedure, but you can see that because we reduce the wall stress, the ejection fraction of the remote zone is increased. So these are examples of the pre and post. This is a more classical left ventricular aneurysm, as you can see, because there is a neck over there. But the neck is shown classically by MRI. There is no other examination that can give us this type of information. And this is the patient after the procedure, before and after. This is another patient, big ventricle, there is absolutely no neck in this situation, and after that the ventricle is reduced in a very important way. Another one example, huge ventricle that present an end diastolic volume of 485 millimeters meter square, and at the end he has 57, and this is before and this is after. This is four-chamber view. Once again, look at the anatomical relationship between the right point, the right apex, before and after, completely different versus the new apex that we have rebuilt with this procedure. I think that it's very interesting to see the stroke volume. The stroke volume in this type of the patients, because it's a chronic disease, sometimes it's higher than the normal. In the FDST group of the patient, they have no reserve, no contractile reserve, so they are in class 2, but they are incapable, class 3, to do some more. In F, there is no more contractile reserve. And after the procedure, the stroke volume is reduced to normal volume, and the patient presents again a new contractile reserve, and he's changed its functional class. This is our experience, that you say the great majority of the patients have anterior, but we have 210 patients with inferolateral dilatation. All patients were treated as techniques I have shown you before. What is interesting is the age of the patient, that is a change in the last period. And another thing is that you have to say is that in that period, the typology of the patient that we treated was the classical left ventricle dilatation, left ventricle aneurysm. Nowadays, we treat the dilatative cardiomyopathy due to a global dilatation. And if you see the difference between the posterior, anterior, or anteroposterior dilatation, you can see clearly the mitral regurgitation, as expected, was more present in the posterior one than the anterior one. You see the ejection fraction of all the group is low, 34, 32, 22, and the volume, the end systolic volume, it's around 80 and 95. These so are big ventricle, and normal ventricle is 35. It are big ventricle with low ejection fraction. And these are results that are achieved after 10 years single-centric experience, so a long follow-up. You see that we have an important reduction of the volumes, important reduction, this is really important, 80 end systolic volume index, after that 54, and this is changed the life expectancy, we will see later. The ejection fraction is increased. What is interesting is to see the sphericity index. The sphericity index is worse after the procedure because we reduce the longitudinal diameter. But what is important is there is an improvement in the conicity index, and the conicity index is the major risk for diastolic dysfunction. So we correct in some way the conicity index. And this is the cumulative risk of death for all causes. You can see at 10 years, 75% of our population is alive. And if you see the risk of rehospitalization, we know that patients in heart failure are very costly for the society because the rehospitalization. In our group of the patient with the characteristics that we have seen, at 10 years, about 25% of the patient need rehospitalization. And if you see the life expectancy according with the volume that we have left after the procedure, you see that if we are good enough to achieve a volume less than 60, and this happened in 85% of the case, the life expectancy is really very, very good, around 75% at 10 years. It's a little worse if the ventricle is bigger after the procedure. So if we had this type, if you have this type of result, why the stitch trial demonstrate no benefit of this procedure? It's very simple, and I think that Professor Turina was tell us the reality of the thing. The first thing that was during enrollment, the stitch trial relied heavily on the clinical judgment of the study physician to ensure that potential benefit and risk to patient were equivalent. Because varied physician thresholds for equipoise in the treatment assignment were permitted, there was a wide diversity in characteristics. And this was absolutely true. During the randomization period, I randomized personally 29 patients, but at the same time I did 122 reconstruction of the left ventricle. And this is the paper published by PI of this study, and said that the primary ethical concern guiding equipoise for randomization was to offer patient treatment combination judged to have similar long-term mortality. So there is a huge bias of randomization, and this was clearly shown and commented by this editorial published in New England Journal of Medicine. The other thing that can explain this type of result was the volume that was achieved in a stitch population. You see that if we compare the percentage reduction of volume in the stitch is really very it's lower than the other published by other groups. And this why? Probably because there is some groups that have no enough experience. The other reason is that if you treat patient is globally dilated with a big spherical ventricle, the reduction of the volume is not easy to be achieved. In effect, if you see end systolic volume index change in the stitch trial, you see that in the group of the patient with end systolic volume index below 60, there is no reduction at all in 43% of the patient. In the group between 60 and 90, there is no reduction at all in 20%, and in the bigger ventricle, there is no reduction in 21%. So in this huge population, there is no absolute benefit because there is no reduction of the volume. And these are the data also published by Carey Lee. You see clearly that the major risk factor to death is the volume. Bigger is the volume, higher is the mortality at 5 years. There is a sub-study published last year, 2013, in which were considered the volume achieved after the procedure. Once again, a survival benefit was present if the volume was less, end systolic volume index was less than 70 milliliters. So this is the data from the stitch. You see that the life expectancy of the patient with relative good volume below 70 and over 70, it's completely different. So this is the volume where we must arrive after the procedure. For all these reasons, in the guidelines published by European Society of Cardiology, this procedure is taking account for the patient that have a big ventricle when there is angina, and the patient with scarred left anterior descending territory with big ventricle, of course, presenting predominant heart failure symptom. Same thing in American Heart Association guideline. So this procedure seems to start to have some credibility in the cardiological environment. So in conclusion, SVR must achieve an important volume reduction. The volume after SVR impact life expectancy. End systolic volume less than 60 is the ideal goal. Sphericalization, left ventricle should be avoided. And this data reinforce the data for using the SVR. Of course, and as was stressed out in the guidelines, it's a heart team works, and technically is not particularly demanding. What is really demanding is the good selection of the patient, and we have to know that we have a very good tool for this type of the patient that very often, because of comorbidity, because the age, you have no other choice to increase the quality and to increase the life expectancy. Thank you so much for your attention.
Lorenzo, these are really excellent results. I fully support your statements. My only question is, do you really, you alluded to it, do you still see the same number of patients, or is it going rapidly down? The reason why I ask it is in Switzerland, this type of patient has disappeared.
You are right.
Treatment of immediate PCI, anticoagulation, lowering of the blood pressure.
The numbers
I still see these patients a lot when I go to operate in Croatia. Then I see the same that you have shown.
You are perfectly right. 10 years ago, I performed at least 110 cases a year, and our workload was higher than the workload that we have now globally for the cardiac surgery. Nowadays, I perform 30-35 cases a year. You are perfectly right that this type of the patient is decreased, but this is decreased not because they don't exist. It's decreased because the patients are treated in different way. When a cardiologist sees a patient with enlarged ventricle, his last thinking is to send to the surgery. He put a defibrillator, he put a resynchronization, he treat medically, send to the cardiac surgeon the patient at the end stage, where there's sphericalization, it's almost complete. This is particularly true because we see that after 1, 2, 3, 4 angioplasty, for example. And so a good candidate become a bad candidate. So probably the global number is almost the same, but it's treated completely different nowadays.